Hi, so I'm Meryl. My topic is hemodynamic monitoring, which is the blood flow through the cardiovascular system. So when we talk about the flow through the system, why is that important? Well, we know that the blood carries much needed oxygen and other nutrients to the body, so that if the organs and tissues in the body do not have that blood flow, then their perfusion will decrease and they're at risk of damage and potentially tissue necrosis and death. So it's really important to be able to measure hemodynamics of critically ill patients in the hospital, and also of patients who may come in who are severely dehydrated, to determine what their fluid status is. So let's start off with central venous pressure. So the items I'm going to talk about and cover today are central venous pressure, pulmonary artery wedge pressure, blood pressure, mean arterial pressure, and cardiac output, also heart rate and stroke volume, and systemic vascular resistance. So let's start with just remembering how the blood flows through the heart. I think everyone has a good idea of that. And the venous return comes in to the right side of the heart, then goes out to the lungs. Oxygen is received in the blood, left ventricle or left heart, and then pumped out to the circulatory system systemically, and then the tissues absorb the oxygen and other nutrients. So in the pulmonary artery, there is the exchange of gas, not in the artery, but in the alveoli. And we'll start with central venous pressure. So central venous pressure is the pressure in the right atrium. And that is measured by putting a central line venous catheter into the right atrium. And what that's important for is that really tells us about someone's fluid volume status. So in hypovolemia, there is decreased venous return, so decreased preload, and there's going to be decreased cardiac output as a result of that. In hypervolemia, there's going to be fluid overload, so the body's going to have too much fluid. You're going to have an increased venous return and an increase in cardiac output. So decreased central venous pressure is, we see that in hypovolemia. Also, and some of the causes of that are hemorrhage, burns, severe dehydration. The treatment for that would depend on if you lost fluid, give fluids. If you lost blood, do a transfusion. And the IV methods are IV, you can use saline, colloids. But really, why is this used? Well, it monitors venous return and it indicates overall fluid status, as I mentioned before. So, and then in increased CVP, you have, in addition to hypervolemia, you could potentially have heart failure, you could have cardiac tamponade, pulmonary embolism, and heart failure. So the treatment is really directed at the cause. So if you're hypervolemic because the heart is not pumping appropriately, and it's determined that the heart is not contracting appropriately, then something like digoxin, cardiac glycosides, that are going to increase the contractility and to increase the cardiac output. If there's fluid overload, you will also probably want to do something like a diuretic, so to decrease the fluid volume, to decrease the load on the heart that's failing, that's not working right. And so it's really directed at the cause. Sometimes it's a combination of those. Now let's talk about pulmonary artery wedge pressure. So pulmonary artery wedge pressure is the pressure that if you insert, it measures left atrial pressure. So pressure in the left atrium. And is measured by using a pulmonary artery catheter. This is a Swan-Ganz catheter, and it is inserted into the right heart and then fed out through the right atrium, right ventricle, out the pulmonary artery as far as it can go, and then they blow up a balloon to wedge it, meaning that it is blocking blood flow. So the blood flow at that point, at the very end, is holding up a static column of blood. So that approximates what the right ventricle the blood flow to the right ventricle and that pressure. So why is this important? Well, it's going to tell us how the heart is doing. So when you have increased pulmonary artery wedge pressure, that happens when you have left ventricular failure or something like mitral stenosis. So when there is a backup of blood, the blood cannot flow forward, and it is going to increase that pressure in the lungs. So that is something that's often monitored in patients who they suspect heart failure. They're trying to figure out what's going on. It's not just a fluid volume status that can be monitored with CVP. And that is really in a lot of critical care. It's done to monitor those patients. So that's really looking at what is happening in the heart itself and how the heart is functioning. Then you have the blood pressure and the mean arterial pressure. So blood pressure is the pressure of the systemic vascular resistance to the outflow of blood from the ventricles. So it's measuring the arterial pressures. And why do we want to do this? Well, when you measure the blood pressure, that's giving you information about how is the blood flowing? Is there not enough blood in the system? Is the blood pressure high? Is there a lot of pressure in the system or on the system, and what is causing that? So low blood pressure could be due to low fluid volume, but it could also be due to systemic vasodilation, which can happen in some kinds of shock. And then you have an increase in blood pressure, which in part could be due to increased or vasoconstriction. So you have increased resistance, systemic resistance in the arteries. The mean arterial pressure is the average pressure in the system that's felt by the organs. So that's the pressure of the blood for the organs themselves. And we know that there has to be a certain amount of pressure there for the organs to perfuse sufficiently. So we measure this with a blood pressure cuff. Also measure it with an arterial line, a peripheral arterial line. And the other thing that the arterial line can do is you can take ABG, so blood withdrawal for ABGs. Then we have the cardiac output. So cardiac output is the heart rate times the stroke volume. So it is measuring the amount of blood that is ejected or pumped out of the left ventricle in 1 minute. And the average amount is about 5 liters cardiac output. That can vary. If you're exercising, you're going to put out more, or going to have increased cardiac output. And if the heart rate increases, then that's going to increase stroke volume. And you see that when patients are in the beginning or going into shock, they have very low blood pressure, and to compensate, the system is trying to, the sympathetic nervous system is going to make that heart, cause the heart to contract more forcefully, faster faster. Sorry, not more forcefully, just faster. But the contractility of the heart is due to the Frank-Starling, or can be explained by the Frank-Starling equation. So you have, that is where you have increased preload, so increase in venous return, or in the case of the left heart, you have increased filling, that's what preload is, which is going to increase the stretch. So those muscles in the cardiac muscles are going to stretch in the myocardium, and then they're going to contract more quickly because they've expanded more strongly, and that is going to increase the pump out of the blood is pumped out of the heart to the systemic flow. So where do we see an increase in preload? Well, an increase in preload is going to happen when there are certain diseases with the heart. If there is a pulmonary embolism and that is big enough to lodge itself in artery or multiple arteries or arterioles, capillaries, and really cause a backup, then that pressure is going to increase in the right ventricle and right atrium because the forward flow of blood is impeded. So at that point, preload is going to be increased, but it won't necessarily, preload is going to be increased, but it won't necessarily increase cardiac output because the flow forward is being impeded. But in the case of someone who's fluid volume depleted, the more fluids you give them, you increase the preload, you increase the cardiac output. So what we're doing by increasing the preload is we're, by the Frank-Starling equation, increasing the contractility, and when it contracts more forcefully, more cardiac output. And then we have afterload as well. Afterload affects cardiac output. So how does it do that? Well, if you have increased afterload, so let's say vasoconstriction or arteriosclerosis in the aorta or aortic stenosis, there is going to be difficulty for the right ventricle to pump the blood out during systole. So that is actually going to cause a decrease in cardiac output. When you have decreased afterload, in cases of systemic vasodilation, then you are going to have a situation where you're able to pump more. You don't have as much resistance, so the heart will be able to increase its cardiac output, so it doesn't have that resistance to flow. So that covers everything I wanted to discuss. Thank you for your time, and happy hemodynamic monitoring. One last thing is, I forgot to mention at the beginning, is you can, by observing a patient, that gives you information about their hemodynamic status. So this is just talking about measuring. But when you are looking at a patient, touching a patient, you can see, are they alert and oriented? Okay, enough blood is going to their brain. You can see, oh, they're pink. Okay, then they have perfusion to their skin, their organs. Do they feel warm and dry or cold and clammy? If they're warm and dry, they have good circulation. So their hemodynamics, their blood is flowing well. So they are doing okay. It is when they're cold and clammy that the blood is being diverted away from the surface due to vasoconstriction, and they're cold, there's a weak pulse. That's going to tell you that they don't have sufficient blood flow through the vasculature. So just always keep that in mind, that you can look at someone and get their physical blood pressure and get a sense of how they're doing, whether or not they're have enough systemic blood flow or not. And that's it. Thanks.